Okay, dear students of batch 21. So today's lecture we will be seeing about the management of malignancies of the maxillofacial region. So you have, so far we have been dealing with the pathologies of cyst and tumors. I think the last previous classes would have been discussed about the removal of cyst and tumors. While they all carry good prognosis, means like the disease is localized, the lesion is localized, and when you operate on it and then you expect some healing to occur, and then the prognosis is excellent, unless otherwise they have the patient did not have noticed it, and then the lesion has gone extensive by its nature, by its invasive nature. But this is not the case with malignancy. Malignancy does not localizes itself within the tissue in which it grows, already very well. So it metastases. Metastasis, that is, this capability of spreading into other tissues, invading other structures, including the nerves, bones, and the lymph nodes and whatnot, all the tissues of the human body. So that is why it is being scared of. Actually, the word cancer, which the common public uses to designate the disease, is actually malignancy. The public is much afraid of the word cancer because it is fatal once it is not um, diagnosed earlier. Unluckily, due to early detection, many of the adverse outcomes have been already averted, and many people lead a normal life uh, once they have been detected with this lesion. As a general dentist, we all who will be starting our practices, or we would have started our practices much earlier, and you would be starting your practice earlier. We all have a very important responsibility of detecting these lesions at much earlier stage. So because the earlier it is being detected, the the better the prognosis, the simpler the treatment, the less invasive the treatment is, and then the better the prognosis, of course, with much lesser cost incurring to the patient. So it is of paramount social importance. It is not only of surgical importance or the disease as such, but it is of paramount social importance because over the period of time we have seen how many families have been devastated, especially the poor families have or middle income families have been devastated because once they get this disease. And you people should be very considerate of this. You people should be very cautious about this. You keep in mind in your routine practice. You have to be very watchful and then detect these neoplasms at very early stage so that you avert a big amount of danger to the patient visiting you. Okay, fine. So what is oral cancer? So it's a new growth, or this is an abnormal neoplasm in the mouth, and then first they are found in most cases by the dentist or by the person themselves. They are usually squamous cell carcinomas. Okay, you know already how to differentiate between a benign ulcer and malignant ulcer depending upon the clinical examination. You know very well how it will look like the surface of the ulcer, the duration of the ulcer, which is of long duration, the rolled out margins, the clinical evidence of lymphadenopathy. All these things are of course coupled with the patient's detrimental oral habits like smoking or chewing tobacco or the other oral habits. So chewing habits. So you will be knowing about how to detect these cancers at a much, how to differentiate between benign ulcer and a malignant ulcer. Remember, in your routine practice, never even utter the word cancer to the patient, because the very idea or the very suspicion that I would have developed cancer can have much psychological devastative effects or much psychological impact on the patient's mindset, even on the family's mindset. Never even utter the word, I suspect this as cancer. No. Okay. So if at all you are suspecting these things, you just tell the patient and tell them that okay, I there is an ulcer here, but I expect it to heal within few days, but the ulcer, as you have been telling, is present for a long time. So I just want to take a precaution, and then I just want to really know what this ulcer is, because I suspect that ulcer might be harmful. If it is not harmful, then it's wise, but we have to be cautious in checking this. So in this way, if you are telling the patient, you will mitigate all the anxiety. So patient will be having more hope, and then the science also says that the willpower of the patient is also um, uh, playing a major role in fighting up the cancer. So let us not utter the word cancer to the patient at the time of initial diagnosis. Even then, unless otherwise your biopsy report proves, you cannot commit that it is an oral cancer. Okay, so when you are writing in your requisition form for biopsy report, don't write the histological diagnosis, what you suspect. Provisional diagnosis, it can never be squamous cell carcinoma. Okay, provisional diagnosis is a malignant ulcer. If you are suspecting so, don't histologically type it, classify it, because you don't know. Unless otherwise the biopsy report comes to you, you don't know what type of cancer it is. So all these things you have to keep in mind as a general practitioner. Okay, it's also very important for you to communicate with your fellow colleagues, because oral cancer cannot be treated by a single person. A surgeon coming inside an operation theater and then he does the work, and then he's not the one who is treating it. You know, in many hospitals there is something called as a tumor board which is being established. It consists of a group of specialists who are the oral medicine people, oral pathology, oral physicians, oral pathologists, oral surgeons, and chemotherapist, radiotherapist, physiotherapist, um, general dentist, of course, prosthodontist, of course, and occupational therapist, and it contains, the list goes on. It contains a group of people um, who will gather to decide on what is the particular treatment for the patient. So it is not a single person's decision to carry out the treatment. It is a team's decision, and you remember that it is always carried out as a teamwork. So the patient has to go through multiple visits of mm, treatment, to multiple visits to multiple specialists during the treatment course. It starts from detection till the rehabilitation. They have to go on for multiple visits to various specialists. Okay, so this goes like that. Okay, right. So who are at risk of developing cancer? People over the age of 40, so maybe a smoker or a drinker. So if the patient is having uh, smoking and drinking as well, the chances of developing oral cancer is more. And many people associate the human papilloma virus 16 and 18 with the incidence of squamous cell carcinoma. Okay, it can be of viral origin as well, but majority of the people develop the cancer with these habits. I mean, they have the smoking and drinking habit. In general, we can say that it is associated with use of tobacco, either smokeless or smoking tobacco. Okay, fine, right. So the site distribution, where all it can occur, where all you can find the neoplastic growth, almost everywhere in the oral cavity. See, you see, lip, tongue, floor of the mouth, it can happen. Gingiva, it can happen. Buccal mucosa, it can happen. Retromolar trigone, it can happen. It can happen. Hard palate, it can happen anywhere in the regions of oral cavity. Nothing is bad. Nothing is bad. Okay. So where all it can occur more frequently, we will see in the next slide. Yeah. So the majority of the occurrence is in the tongue, floor of the mouth, followed by floor of the mouth, then followed by retromolar trigone. It can happen in hard palate, can happen in gingiva and buccal mucosa. So in case of people who chew on the tobacco, the site in which the chewed tobacco quid is being lodged is the site of much preponderance to develop CA, because it is directly in contact with the irritant. Some people have the habit of lodging the quid of chewed tobacco within the in the vestibular fold, in the mandibular vestibular fold. Some people have the habit of lodging it beneath the tongue. So accordingly, the site of occurrence differ. Okay, it can present itself in so many sites that we have seen. The histological distribution, the majority is squamous cell carcinoma. Majority is squamous cell carcinoma, and of course with the salivary glands, melanoma, lymphoma, and sarcoma, they are all also affected. Remember the word here, what they have mentioned is minor salivary carcinomas. So leave the carotid, submandibular, and sublingual glands. So when there is a neoplastic growth in association with the minor salivary gland, which is distributed almost everywhere, including the hard palate, your buccal mucosa, and other areas. So when these salivary glands develop a neoplastic growth, what they say is that the most likely is a malignancy. Okay, so it is not like in case of our salivary gland tumors, which are affecting the major salivary glands, they are mostly benign. That is pleomorphic adenoma. But here it is, I mean, it may be a malignant tumor of the salivary glands. Okay, so you have to keep this in mind. Then the racial distribution, of course, I think the Indian race is much affected with around 5.2% occurrence in male and then 7.7% occurrence in female. Okay, so they're genetically predisposed to develop oral cancer. So the clinical presentation. Well, you know that most of the patients will present you with an ulcer which is not healing, and then you can see some lumps or white or red patches. There is unusual bleeding, pain, or numbness, and there is poorly fitting denture because of the growth. So as a result, there may be difficulty in speech and mastication because the tongue movement may be affected, and there will be trismus, loose teeth, or nerve involvement when there is extensive involvement of this lesion into the adjacent muscles and nerves, and there is restricted tongue movement, excessive salivation, and there is always a submandibular salinitis. There is a superinfection of submandibular gland. Um, so what you have to keep in mind is that yeah, there is all these things are possible. Beware of numbness. There is an ulcer in the lower arch, and then you examine it, and then you check for the numbness. When there is numbness, something should alarm in your mind. Oh, this ulcer may be a malignant one. This may be a dangerous one. Then in the absence, in an apparently healthy, fairly good oral hygiene, you detect some unusual mobility in the lower arch or upper arch. So in that case, you take an OPG, and then if you find that there is an unusual mobility for that for the component of oral hygiene you have measured. So when there is unusual mobility, you have to uh, when you come to know that there is a positive history of tobacco use, just check an OPG to know for to just to know whether there is any invasive alveolar destruction because the tooth is mobile. Because what happens is that in case of maxilla or mandible, there would have been some alveolar growth. The CA would have gone infiltrated into the alveolus from the gingiva. It can got infiltrated into the alveolus because it can easily spread into it, and then it can grow from underneath. In other words, you will not be able to see the growth when intraorally. But when the patient comes to you, there will with the mobility, you will think that it is a chronic periodontitis, and then you will extract it. The moment you extract, the next week you can see a fungating growth from the alveolus. Okay, and if the patient is not educated enough, he will blame you that only because of your extraction he has got cancer. Such things have happened in our practice. So when there is an unusual mobility, you check with an OPG. Okay, that should alarm your mind even when it can happen in with CA maxillary antrum as well. It can pop out as a fungating growth the moment you would extract the tooth. So be careful in these aspects. Always check for this. Even when you want to know whether it is a malignant ulcer or not, check for the lymphadenopathy. Check for the lymph nodes. They will tell you. Okay, fine. So the workup and staging. So how would we go about once it is being diagnosed as CA? So, I mean, you suspect a CA. So you do the complete physical examination. So there is dental evaluation with the preoperative dental care. You have radiographic evaluation. You have histopathological examination, the biopsy that you do, and then of course you have to liaise frequently with the general medical condition. You have the, I mean, you have to liaise with the patient's physician, and then the nutritional status should be evaluated, and then the evaluation for the presence of other predisposing factors for CA should be done. The most challenging thing which we will face when we are taking the patient to the CA patient to for general I mean for the surgical treatment is getting obtaining and fitness from anesthetist, because all these patients will have nutritional deficiency, especially anemia. When the anemia is very severe, the anesthetist will not give fitness. They will wait till the hemoglobin status improves, and then only they will allow, and then they will take up the patient for surgery. So because of the risk versus benefit of the other potential complications associated with anemia, so this is a hurdle actually, which the patient have been detected earlier, but they have to wait for a particular period of time till their hemoglobin level picks up, so that they will undergo a safe surgery. Okay, these things are some of the things which you have to practically keep in mind. And your routine examination, to examine the skin of the face and scalp. And as an I mean, as a dentist, you will be having, you have to meticulously examine this oral cavity, the mucosa of the oral cavity. You have to examine the oropharynx, and you have to look for the presence of lymphadenopathy during in the cervical chain, that is cervical lymph nodes. Salivary glands have to be examined. The cranial nerves have to be examined, especially our trigeminal and facial nerve. And paresthesia of the areas innervated by the trigeminal nerve will give you a clue that there is an evidence of neural invasion. So other than that, you have to examine the mucosa of the nasal cavity, nasopharynx, hypopharynx, and larynx. Otherwise, I mean, as well. So this examination of oral cavity must be done in a meticulous way, so that none of the area is being missed. We have been conducting our more oral mouth cancer awareness week. Um, I don't know, if things improve, it's fine, or else we may have to conduct that entire oral cancer awareness week online only, with the Zoom meeting, in which you have to almost call all uh, the local population of Penang in Zoom, and then to check their oral cavity. I don't know how it's going to happen this year, but I mean, as a dentist, you have to be meticulous um, in examining the oral cavity, especially both the hard tissues and soft tissues. Soft tissues already you know that the tooth you can examine, but regarding the soft tissues, you have to be very meticulous. You will not miss an area if you are following a particular order. Okay, so it starts with your lip mucosa, labial mucosa. When you go back to gingiva, you just make an order by yourself that you have to start from anteriorly to the posteriorly. Okay, so if you start from the examination of mucosa, labial mucosa, then you go to the gingiva, then you go to the uh, the immediate posterior, that is the hard palate. Then you go to the soft palate. Then you examine the buccal mucosa. Then you examine the tongue, dorsum and lateral both. Then you examine the floor of the mouth. If you follow a particular order, of course with the lingual gingiva, if you follow a particular order, you will not miss any area. So these are all the various steps of how you can examine the soft tissues. Then our TNM staging. You know, I mean, I think from oral pathology or from the general medicine aspect, you will be learning much about the TNM staging. T stands for the tumor thickness, N stands for the nodal metastasis, and whereas the M stands for the distant metastasis. Okay, fine. So how would you classify the cancer? How would you stage it actually? It is from carcinoma in situ, and as the diameter of the tumor increases, you will be staging it as T1, T2, T3, and T4. Remember, in T4 here, they have not given any particular dimension. Okay, you make a note of it, because when others T1, T2, and T3 are having their own classification depending upon the size, whether it is, if it is less than 2 centimeter, you have to designate it as T1. If it is between 2 centimeter and 4 centimeter, you are designating it as T2. And then when it is more than 4 centimeter, designating it as T3. But for T4, they are not giving any such particular dimension, because however small it is, when the tumor is able to invade the adjacent structure, maybe the bone or the nerve or anything, when it is capable of invading the adjacent structures rather than the nodal metastasis, it should be done under T4, which means if the tumor is of T1 size, but you know that you are able to see the evidence of invading the adjacent structures in your OPG or other things, or your MRI findings or other things, you should designate it as T4. Okay. Okay. Don't just assess the staging of the tumor by looking at the size alone. This is what it implies. So the T stage of orofacial cancer, you know how it is this, like 2 centimeter, T1, T2, T3, T4A, and T4B, which is depending upon the extensivity. Okay, you can look a closer look at the slides when you're going through the lecture notes as well, which will give you much understanding. And then you have a group of lymph nodes which you can um, assess. So we have categorically classified into levels 1, 2, 3, and 4. Level 1 starts with your submental and submandibular, and level 2, 3, and 4 will be with upper jugular, mid jugular, and lower jugular, and level 4 is the posterior triangle, and level 5 is the anterior triangle. Okay. So the levels of lymph nodes again. So the level 1 stands for the when there is an involvement of lymph nodes in the submental and submandibular triangles. So 1A is corresponding to the submental triangle, and 1B is the triangle which is formed by the anterior and posterior bellies and of digastric and body of the mandible. So why should we be worried about the lymph nodes? Because the CA can extend to the lymph nodes first. So without clearing the lymph nodes, if you are leaving the lymph nodes as such, and then you are clearing only the lesion, surgically treating only the lesion, you have done only half treatment. Your treatment is impossible. Your treatment is incomplete. So we have to clear, we have to assess actually where are this metastasis has happened in the lymph node, and then you have to clear all the levels. That is why they have classified into levels. Okay, they follow a particular pattern depending upon the duration of the CA lesion. Then the duration of metastasis, I mean the extent of metastasis will vary. So you accordingly there are various type of procedures. They are called as neck dissection procedures, which will address all the lymph nodes, which will clear all the lymph nodes and associated structures. In fact, your lecture of part 2 in the management of malignancies of oral cavity purely deals with neck dissection. So I will just go through the various types of neck dissection, but in detail it will be discussed in the next lecture. Okay, so now corresponds with the upper third, including the upper jugular and jugulodigastric nodes and the upper posterior cervical nodes, and then level level 3 deals with the middle third jugular nodes. It extends from the carotid bifurcation to the inferior edge of the cricoid cartilage. Okay, level 3. And level 4 is the lower jugular level, and then they extend from the omohyoid muscle to the clavicle inferiorly. Level 5 is the posterior triangle. So it involves it is bounded by the trapezius muscle and then the sternocleidomastoid muscle anteriorly. And then the anterior compartment group, level 6, which comprises the lymph nodes surrounding the midline visceral structures of the neck, extending from the level of the hyoid bone superiorly to the suprasternal notch inferiorly. Okay, so these are all the various regions that have been mapped and then identified, into which the most of the cancer from our oral cavity can metastase into. So, which means that it is imperative to surgically remove all these lymph nodes and associated structures along with the ulcer to for a complete therapy. Okay. So for that, they have to just like that we have staged the the tumor size. We have staging the extent of lymph node involvement. So you have this regional lymph nodes which cannot be assessed from NX to N3. You have the lymph node metastasis. N0 you are not able to know. I mean, N0 there is no regional metastasis. You have confirmed it, and then N1 there is metastasis with a single ipsilateral node which is more than 3 centimeter in greatest diameter, and then N2A single ipsilateral node which is between 3 to 6 centimeters, N2B multiple ipsilateral nodes that is on the same side. All these things are happening on the same side, more than 6 centimeter in greatest dimension. That is, and then when there is a bilateral lymph nodes um, which is less than 6 centimeter, and then bilateral lymph nodes in any lymph node with more than 6 centimeter in diameter can present it as N3. So it accordingly stages from NX to N3. We have to learn it by heart. We have to learn it by heart. The T1 TNM staging we have to learn it by heart. Okay, just like learning a multiplication table. Okay, so that you will be asked questions regarding, you will be given a picture, and then you will be given a scenario in which how the case looks like and where all the lymph nodes are metastasized, and then you have to work out from your learned staging. You have to work out the staging in actually which stage the cancer is. This is an important ASCII question for you, or you most probably we will be keeping ASCIIs from this CA. Okay, so as a general dentist, you should be knowing how to assess a CA, and then you should be able to roughly or approximately uh, stage the cancer. Okay, fine. So see, this is a pictorial representation of various different types of lymph node metastasis: N1, N2A, N2B, N2C, and N3. This is just a pictorial representation. You will be able to understand it better. But as I told you, you have to learn it by heart. There is nothing much to explain in it. So why these nodal metastases are important? How the primary site of the lesion is corresponding to the nodal metastasis. What they say is that as we go from lip, tongue, gingiva, flora of the mouth, oropharynx, and hypopharynx. So the tongue, flora of the mouth, gingiva, when the primary lesion is happening in these areas, the corresponding likelihood of being metastasized to the regional lymph nodes is higher. And then the highest is being when the lesion is being found in the hypopharynx, the metastasis is higher. So as the lesion progresses closer to the levels of lymph nodes, the more probability of being having a positive neck node is more. Okay, fine. Then again, the relationship between the tumor thickness, nodal metastasis, and death. So it clearly indicates that the more the size of the tumor, the more it can metastasize. The more it can metastasize, the worst is the prognosis. And then the worst outcome out of the cancer would be death already. Death. Okay, it's a fatal disease. So radiological evaluation, we have all the um, various modalities. It starts with our routinely used IOPA, which can show you the abnormal infiltration, and then panoramic is of, OPG is of much value, because you can study the entire mandible, and then you can study the extent of bony involvement. Remember, OPG gives a magnified image. The size of the lesion which you are seeing in the OPG is not the life size. It will be lesser. Okay, fine. Then you have the CT and MRI. Extent of involvement of a bone. The hard tissues can be studied very well with the CT, whereas extent of involvement of the soft tissue is can be studied very well by the MRI. Okay, and then you have the tertiary referral centers may have the bone scans to detect the bony invasion, which is much more earlier than the X-rays, because already there is you have to demineralize around 65% of bone to evidently see the radiological evidence of the cancer, but these bone scans can detect it much earlier. Okay, but however, the most convenient and then the practically used um, I mean imaging modality for detecting for your routine in your routine clinical practice will be your OPG. OPG. Okay. Fine. So once the patient is being diagnosed with CA, then you have to do all this preparatory phase in which you have to carry out the unwanted tooth which are having poor prognosis for extractions, and then you have to do a scaling and the other oral prophylactic procedures. You have to restore the tooth which can be saved, and then your oral surgeon will communicate with you to the extent of the loss of the tooth structure, the extent of involvement of the bone that is going to be taken out, so you can construct obturator or splint prior hand, so that the patient will have less time in during the prosthetic rehabilitation. So these are all the various stages in stage 0, stage 1, stage 2, stage 3, stage 4, and which is divided into A, B, and C. Okay, this will give you an idea of the prognosis and operability of the lesion. Okay, is it going to really, I mean, prove worthful? Okay, and as a rule of thumb, the lesser the stage, the better the prognosis. That from which standpoint of view, dentists play a very important social role. Okay, fine. The treatment of oral cancer can be, it's not, I mean, majority by the surgery, but it can be coupled with radiation therapy also, and then you have the chemotherapy as well. Remember, for oral cancer, chemotherapy has very limited applications. Not as a therapeutic, but as a supportive measure, it can. But as a therapeutic measure, chemotherapy has very limited applications. Only we have surgery and radiation therapy. Okay. So I have told you that in the initial, before designing on the treatment, how to go with it, whether it is a single modality or multimodality. So if it is a multimodality, what all things we have to take it up, whether we have to take the patient for surgery, or we have to, we have to augment it with radiotherapy, or we have to supplement with chemotherapy. All these things will be decided in the tumor board. Okay, each and every specialist will give their opinion, and then they will arrive at a consensus. Okay, for this case, first we will take for chemotherapy, or first you take for surgery, or first you take for radiotherapy. All these things will be decided in the tumor board. So when there is when the stage is very small, earlier stage, then you can have single modality treatment, mostly surgery. When the for an advanced stage, you will have this multimodality treatment, which may include chemotherapy and radiotherapy as well. So what are the factors which determine it? So the type of tumor, size of the tumor, how big it is, location of the tumor, tumor thickness, neck metastasis, and how differentiated it is, and then the extent of perineal invasion. It will tell you the biological behavior, and bone and cartilage invasion. It also will tell you the biological behavior. When the tumor is so much invasive to invade the bone and cartilage, it is very aggressive. It is very aggressive. So what are the surgical approaches to the oral cavity? When you see when how the surgeons would approach the lesion and then to take it out, so you can have per oral, when you do nothing, just through the oral cavity, just the oral cavity gives you an access, and then you can do just like what we do, our regular extraction, regular alveoloplasties, minor oral surgeries. We don't do anything extra, we just ask the patient to open the mouth, and then we are able to access that area. Like that, the CA will be very small, so that you can per orally, just through the oral cavity, you can just access the lesion, and then you can carry out the surgery. When the location of the lesion is trickier, it is more posterior, it is very inaccessible, then you have to do something called as the access osteotomies. So in this case, what they have done is the split mandibulotomy. That is, you are intentionally creating a fracture, you are swinging open the mandible or maxilla to approach the area which is otherwise inaccessible. So, say for example, when there is a posterolateral location of the CA lesion, here in this case, so they have cut open the mandible, and then they operate in that area. Once the work is done, they will put back the mandible in position and then plate it, just like what you do at fracture. Okay, fine. And then this is a visor flap, which is a degloving incision. It can show the entire region of the mandible. The inferior border and body of the mandible can be seen, and then you can carry out the procedure. This is the upper cheek flap for the maxillectomy procedures, which is used by the Weber-Ferguson incision. See, you have seen that incision. It is called Weber-Ferguson incision. This is to expose the maxilla. The previous flaps are used to expose the mandible, whereas this is to expose the maxilla. You can carry out the procedure after retracting all the soft tissues after the placement of incisions. Weber Ferguson incision, you can place the incision and then you can carry out you can retract and then you can access the area. So this is after the surgery. And then you have marginal mandibulectomy, in which you will be taking out a part of the lesion along with the invaded bone. Provided that if the invasion is very minimal, you will leave the inferior border intact. So with the preservation of continuity. And when the region is very extensive, then we have no other go. We have to include the inferior border, and then this region is with continuity defect. So these are all the various surgical treatment modalities that we have seen. So although the next lecture is going to be extensively through the neck dissection, I will just take you through brush you through the major neck dissections that you will be taught with in the next session. So we have section. It is considered as the standard drug dissection, which includes all the levels of removal of all the levels 1, 2, 3, 4, and 5, as well as the muscle, the spinal accessory nerve, and internal jugular vein. Almost all the lymph node levels and then the important organs are sacrificed in it. Okay. This is a just map of radical neck dissection. It is commonly called as RND, and then the structures removed is submandibular gland, sternocleidomastoid, internal jugular vein, spinal accessory nerve. All these can be removed. So this is very extensive. So of late, what they were able to narrow down in an attempt to preserve the vital structures, in an attempt to take only the nodes which are affected, they have modified it into a more conservative approach, which is called as modified radical neck dissection. uh, I mean, Selective neck dissection with the supraomohyoid, involving the lateral or jugular levels or posterolateral levels and anterior compartments, in which they take out only the lymph nodes in that particular level. And then you have the selective anterior triangle neck dissection, and then supraomohyoid neck dissection. You take out the levels of level 1, 2, and 3 only, along with the submandibular salivary. Neck dissection, you dissect only the 2, 3, and 4 levels. MRND, in which you remove the lymphatic levels, but you preserve at least one non-lymphatic structure. So this is MRND type 1 with the preserved spinal accessory nerve, and then MRND type 2 with preserved spinal accessory and internal jugular vein. Type 3, in which you preserve spinal accessory, internal jugular vein, and the sternocleidomastoid muscle. You don't remove any non-lymphatic structure. You don't remove any non-lymphatic structures. You remove only the lymph nodes. So the idea is this: radical neck dissection is very aggressive. So the patient may have to unnecessarily sacrifice all the important structures. So they have narrowed down to either particular levels of lymph nodes, and then they have still narrowed down to remove only the lymph node and spare the structures which will be of use to the patient. So in that way it goes. Okay. So with this, there is the broad overview of management of maxillofacial, malignancies has been over, and then the next part will be the neck dissection. Um, Thank you. Have a good day.